with IC. So my apologies to the chair in advance. I try to be precise, try to be in 15 minutes. But let's see. Yes. I'll try to continue from where my friend Jihan left. He gave a wonderful overview of all the possibilities in regenerative medicine. And I'll take it from there, talking how we can convert into the clinic in easy, cost-effective ways. So I start my talk with a testimonial, though I don't like a testimonial, which cannot be faked. So that's a testimonial of a spinal cord injured dog. We started with a stem cell application, and along with rehabilitation, you can see a very wonderful result. So even in neurology, bad neurological situations, you can have a result. So I don't have anything to disclose. I am an independent researcher, but yes, I get biased with my own experience. So as Dr. Jihan explained the possibilities of biological therapies, there are so many approaches, right from adjuvants, including, as my colleague mentioned, intermittent fasting, nutritional therapies, ozone. So I'm not talking about that. I'm trying to concentrate my topic on biological therapies, meaning stem cells, blood-based products like PRP, exosome, as he mentioned, growth factor. I'm not touching gene therapy, and of course, not biological drugs. So in blood-based biologicals, every one of us is using blood-based biological in one way or the other, and the most common is PRP. And then we can have a lysate, or we call the growth factor extraction from the blood. There are many companies providing in the name of GFC, growth factor concentrate, and then you have a serum, conditioned serum, platelet-rich fibrin, exosomes, A2M molecules. So I club all this under an umbrella of blood-based biologicals. Talking of PRP, as you will see, there are numerous techniques in the world, talking of different protocol, different product. So we have tried to address what are the key issues. So the key issues are basically leukocyte poor or rich. You can debate the whole day on this. Presence of RBC, of course, as less as possible. Activated versus non-activated. Again, if you are putting the PRP in a tissue which has a collagen, you don't need to activate. The fourth point, the photoactivation, which has come up very recently, I will just touch about it. So, in nutshell, besides all these key issues, the main component is whether we are giving an appropriate dose, that means the quantity of platelets in a particular tissue. This is very, very crucial. So what is quantity? The absolute number of platelets we are injecting in that tissue. For example, we did a very good study published in Nature. In knee, we found out at least 10 billion platelets are important. So I can give those 10 billion platelets in 2 ml, 5 ml, 7 ml. So we figured out 7 ml will be a good dose. Similarly, for a disc disease, 10 billion platelets. And in the disc, we cannot inject the good volume, so the volume has to be 1.5 ml. Similarly, in elbow, 3 billion platelets in 2 ml. For people who are in cosmetics, hair, 2 to 4 billion per centimeter square. So we need to identify the dose, which is very, very crucial to get a result. Now, we talk of concentration. We have concentrated 5 times, 7 times. Perfect. We have to concentrate, but it does not mean that we miss the absolute dose. So what we have understood by now is the total dose is important with a good concentration. So we should have a good concentration along with the dose. Unfortunately, the kits we are using in the market do not give us a very good yield, absolute number of platelets. They give us a good concentration, but they do not give us a very good yield. For example, as you can see in this slide, one of the best kits in the world, M-Sites, Magellan gives reasonably good even then, but yield is only 70-80%. Arthrex, very common in Europe, is the poorest in terms of yield. In this slide, you can see one of my friends, but he did very good study. He could concentrate very nicely, a baseline count of platelets 289 to 1877, very high concentration. But if you see the recovery was 32%. That means he lost a lot of platelets as a waste. So the absolute number of platelets will be very less for a therapeutic effect. So these are a couple of pictures to show you the same thing. Although the concentration achieved was very high, but the absolute count or the yield was poor. So this has to be omitted. And can we check the quality of our PRP? Yes. If you send your sample for ELISA randomly, you can know that you are doing a good job. So I just brush up very quickly how we can produce a good PRP. You can do a single spin. It's not very effective. The best is double spin. You have your, this is again a single spin with a gel tube. There are a lot of tubes in the market, you will see, but again not very effective. This is what I recommend the best. That's a double spin method. You have a tube with a blood. You spin first, you get a plasma. You take this plasma and spin second, very harsh. Harsh means fast, high spin, and you have a pellet of platelets. If you take only the pellet of platelets, you get a PRP, and this is PTP. We have tried to develop a centrifuge, a pre-programmed, in which you can get a first spin, second spin, all pre-programmed as for the tube, and you get a very good product. I'll show you. We have even developed a very good tube with a filter, which we can talk later. I'll just try to explain you the steps. Very simple. You take the blood, you spin first, you get a plasma, then you take out this plasma. If you go up to the Buffy coat here, you get a red plasma, or if you stay above, you get bloodless. You make a second spin, and you see a very beautiful white colored platelet count. You can see in a zoom this is all a platelet pellet. And you can see by your eyes the quality of the pellet you get. You resuspend the only 2 ml, and this is your very good PRP. And you can see in this slide how the PRP differs. This is an ordinary PRP with 2 to 3 times concentration. This is up to 10 times, and this is even up to 40 times. So you can concentrate with 2 steps based on what you need. These are a couple of our studies. We try to compare our method with the established methods in the world, and we could find that our yield was 90 to 94% as compared to the literature. Even the growth factors, we tested ELISA, we checked how many growth factors our platelets are secreting, and we found that the growth factor released by our method was superior to the methods in the world. Well, some people do not want leukocytes in the product, so you can just buy a WBC filter and pass it, the PRP through the WBC filter, and you get a leukocyte depleted PRP. Well, if you want a very high concentrated PRP, as I mentioned 40x, you need a filter where you can pass your PRP. The filter should be less than 2 micron, because the size of platelet is 2 micron. All the platelets are sequestrated here, and then you flush back, you get all the platelets. So in this simple way, you can get a very, very high quality PRP for this disease where you cannot inject more. Then we were talking about the growth factors from the PRP. So the right word is platelet lysate. You lyse the platelets. There are many methods in the freeze, thaw, calcium chloride, thrombin. So the calcium gluconate is a very easily available drug in the market, and we prefer calcium gluconate. You add calcium gluconate, you wait for the clot to form, and then you aspirate from the clot. After the clot has formed, it has retracted, and it is rich in growth factors. So it's only growth factors without platelets. Well, if you want even modify your growth factors, you can keep the whole blood for 3 hours in glass beads. You spin for 10 minutes and you collect this. This changes the secretory pattern of platelets, and you get more anti-inflammatory growth factor, and this product works like a steroid. Very good anti-inflammatory effect. And you can see traditionally from a PRP, the number of growth factors increase tremendously when you incubate for 3 hours. This is our concept now to isolate exosomes from the blood during PRP. So now I call our product as a PRP exosome. That means my PRP will contain highest quality of platelets along with exosomes. How we have done that? We know the size of exosomes is between 150 nanometers, 100 nanometers, 150 and in Daltons. So we just developed a filter of 500 kilodaltons. What happens? The platelet poor plasma which we throw, I concentrate the platelet poor plasma with this filter. So I get a very concentrated soup of exosomes. This concentrated soup of exosomes I mix with PRP and my products become PRP exosome. We have validated. Yesterday I was having a discussion with one of my colleagues. He said the blood doesn't have that much exosomes. So I can explain my colleague also that we get 0.88 billion to 33 billion per ml of plasma the exosomes. So it's a good number. And we did all the validation. Now, this is a new concept, not new, freeze-dried PRP. Do we need to make a PRP every time? No. And we have done this exceptionally good. We are publishing, we have patented, and we are launching. What we are doing? We are taking the PRP, putting in a machine and making a powder form. You don't need to draw the blood every time. You can do allogenic, you can get the blood from the blood bank, and you can do it. So, and you can keep it in your shelf for 6 months, 18 months. And the beauty is, the platelet recovery after freeze drying is 80%. And the growth factors are even better than the fresh PRP. Why? Because we are freeze drying process kills 20% of the platelets and the growth factors are retained. So you get a better quality of growth factors, quantity of growth factors along with reasonable number. And the cost is very, very less. You can have it as an option product. So this is something which is coming in the market. We just tried this on a wound. This is very latest, last month. And you can see day 0 wound, we applied freeze-dried PRP in the margins. And you can see the patient improving, showing signs of epithelialization. The bad wound in 7 to 9 days doing very good. So another topic is platelet-rich fibrin. Many of our dental colleagues are using it. And it's a good product if you don't have big machines. You just need a simple tube, put the whole blood, spin for 10 minutes, and you get a platelet fibrin clot. And you can put it in any defect you want. But if you want an injectable PRF, that means you want to inject, you just need a whole blood, spin for 3 minutes. I recommend 6 minutes at 200 G. This is my recommendation. And from a 10 ml of blood, you get 4 ml of injectable PRF. There is again a debate whether injectable PRF is better or the PRP is better. I do not want to touch into that, but this is again a good option where you don't want to have a double spin, you want to reduce your time. This is again a good option. Now, I was talking to you about can we change the platelet secretome? We know platelets do not have nucleus, but platelets have a mitochondrial DNA. Yes, we can change, platelets change the secretome based on the situation. So now, people have tried to understand if we can, so can we change the platelet secretome with photoactivation? Yes, people are working with red laser, different lasers to, Can we change the platelet or the quality of growth factor in the human being before we take the blood out? This is again a question. Intermittent fasting, as my colleague said, yes. 5 days before you take the blood draw, good nutraceuticals before. Well, we did a study with intravenous laser where we gave intravenous laser for 5 days and then we found the platelet number did not increase, but the secretome of platelets improved. And even the V cells, CD34 cells improved. So this was an overview about blood-based products. I will very quickly go to the stem cell part, which my colleague mentioned. Bone marrow and adipose tissue are the most common. And as he mentioned very correctly, the mechanism is paracrine mainly. These cells in vivo, in human setting, do not transdifferentiate. They give a result only by paracrine effect. And how we can get it? Either we take the tissue out, enrich them, or do the expansion. Expansion is again more than major manipulation, needs big setup. We are talking of enrichment. Again, if your dose of the cells is not appropriate, quantity is not appropriate, you do not get a result. If the quality is not good, you do not get a result. And the cells, especially the fat, they are dormant. If you do not activate, you do not get a good result. What is the right quantity? Nobody knows. But in general, we talk 2 to 4 million per kg of the body weight. Quality. When we harvest the sample or process, if we don't do it gently, we lose the quality. As you can see in this picture, the manual method of Ficol was poorer than the native, that means unprocessed. Unprocessed cells were having better quality than bad protocols. So, isolation protocol has to be good to have a good quality. So this is one article I read. A poor quality bone marrow concentrate was giving results equal to PRP. Activation, as I mentioned, these cells need to be activated because they are dormant. So red light gives very, very good results to activate. Addition of PRP also activates. Centrifugation also gives energy and it also activates. You can see in this slide, the activation, the number of calories have improved after activating. Even the VEGF level of these cells improved after the activation. Okay. In the bone marrow, my tips for bone marrow is do not aspirate more than 3 to 4 ml from one point. Me and Dr. Jihan always fight on this. We have a, it's science. Science is nobody's property. He has a different concept, I have a different concept. We prefer posterior iliac crest. And I made this slide for him. He prefers tibia. So in my opinion, the iliac crest is a better source. Yes, very important. The cannula. If you have a closed tip cannula, you get very good yield. The bone marrow coming only from the slides. If you have an open tip, you get more of the venous blood. You should be parallel. And this is what I do not like, aspirating only from one point. Only from one point. I don't if this is the picture. This was another picture where I was trying to show aspirating from multiple points. Finish. You can process manually or you can process in a machine. This is a Magellan we are using as a point of care, but you can use a lab protocol which is very cost effective. We use that to reduce the cost. And it's a very simple protocol. And what I have done a value addition in this, we have tried to recover the very small embryonic like stem cells, which my colleague mentioned before, from the bone marrow. They are very, very powerful. So, it's not moving. Can you help me, friend? Friend?
Moment.
Not moving. Next. This is not my fault now. 1 minute extra because of this.
You are already 5 minutes.
No, but this is not my fault. I'm coming from the very far. I should get more time. Correct? Yes, you get more. Yes. So the yield is really good. If you do a good job, you get 15 to 18 million CD34 cells. The MSCs are less in bone marrow, so they are less, and you get various progenitor cells. The key is, if you have a cocktail, the results are better because these cells are synergistic to each other. So having a cocktail with natural growth factors is very, very good. Coming to the fat, you have a stroma and a parenchyma. In the interstitial parenchyma, you get the interstitial cells, which are mesenchymal stem cells, pericytes. This is what we want. And adipose tissue is a richer source of stem cells than the bone marrow. And lipoaspiration is easy. What you should do, try to have a syringe with not more than 400 millimeter mercury pressure, not to destroy the cells. Try to balance the fragment, not big size, 3 millimeter, not less. So a 2 millimeter hole cannula is very good. The complications are practically nil. Hematoma, embolization if you are using a blunt force or a blunt cannula. Reducing a blunt cannula will reduce the cost.
We don't have time.
So from the adipose tissue, you can get a microfragmented fat or by multiple transfers, or you can get stem cells. But the process of doing mechanically will not give you very good quality. So it is traumatic to cells, it produces cell debris, very low yield. I'll talk more during my adipose tissue. So you can do an enzymatic processing, or but there are disadvantages. Or you can use a sonication, which is the best process. And the advantage of sonication is it gives the best yield, the cheapest possible way of process. And the literature shows the ultrasonic cells are much better than the mechanical. And that's all. So you can use in every application you want, right from neurology to gynecology to sexual medicine, infertility, diabetes, cardiac, musculoskeletal, pain, wound healing, cosmetic, anti-aging, wherever you want.
Thank you very much. Thank you.